Good afternoon and welcome everyone to this ERN ReCONNET webinar on multidisciplinary diagnosis and multidisciplinary teams treatment in idiopathic inflammatory myopathies. We will have three speakers, Associate Professor Louise Pyndt Diederichsen from Denmark, and two of our patients' ePAG representative, Olga Drapalova and Silke Schlüter. So with this, I give the word to the first speaker, Professor Diederichsen.
And then thank you. So this is today's program. The webinar is planned for not 1 hour. We were mistaken a bit. It's only 45 minutes. So be patient. It's only 45 minutes. And it will be 10 minutes for presentation of the disease group, and that's idiopathic inflammatory myopathies, or shortly myositis, by me. And then 20 minutes with patient stories, testimonies by Silke and Olga. And then hopefully you will have a lot of questions, and we will try to answer as best as we can. So I will start with, I have done with the slides with some questions, which some of my patients will try to have an answer for some of these questions. So one of the most common questions when you have a newly diagnosed patient with myositis is, why have I got myositis? And the underlying mechanisms of myositis are unfortunately not completely understood, but we know that it's something with the interplay between genetic predispositions for autoimmune disease, and that includes rheumatic autoimmune disease, and in combination with environmental factors like virus or medication, which sometimes trigger the myositis disease in patients with this genetic predisposition, and in combination with activation of the immune system. And we are sure of this. We know that there is an activation of the immune system causing inflammation. And I will try to explain what's happening in the body when you have myositis, because we do know that. We might not know the underlying cause, but we know what's happening in the body when you have myositis. So this is really, really simplified. So simplified, the white blood cells, they are the immune system. The white blood cells, together with the red blood cells, the red blood cells will carry oxygen, and the platelets, all of these cells, the blood cells, they are produced in the red bone marrow. The red bone marrow, we have that in all major bones of the body. And when these blood cells are produced, they will flow into the bloodstream, in the vessels, in the arteries, and from the blood vessels, they will have access to all body parts. And that's normally not a problem, that the immune system will have access to all body parts. But when you have a diseased immune system like an autoimmune disease, then the immune system will attack structures of its own body, and this becomes a problem. So the immune system is the white blood cells. The white blood cells flow in the bloodstream, in the arteries, and then they will have access to all body parts, including the muscles in myositis. So why might the disease manifest? And I have borrowed this very nice image from a review by Ingrid Lundberg and other authors as well. I think it's really illustrates the disease quite nice. So you might have the disease, of course, in the muscles, causing muscle weakness, pain, sometimes stiffness. You might have the disease with inflammation of the lungs, with some symptoms as well. I will get back to that in another slide. I will try to speed up. And the vascular system, the cardiovascular system, so not only the vascular, but the cardiovascular system with the heart, the gastrointestinal system as well, the stomach, and finally the skin. Based on the clinical manifestations and the presence of autoantibody, you will be able to subtype myositis. And we have many different subtypes of myositis, and it has developed over time. In the beginning we had polymyositis, and some of you patients with polymyositis have been transferred to another diagnosis, and that would be inclusion body myositis, which is not very rare. In this group, immune-mediated necrotizing myopathy, and that's sometimes statin-induced, anti-synthetase syndrome, dermatomyositis, and if you are a kid and having dermatomyositis, then it's called juvenile dermatomyositis. And finally, overlap myositis, and that's myositis together with another rheumatic autoimmune disease, and that could be Sjögren, scleroderma, lupus, and others. So what are the main symptoms? Of course, it depends on the clinical manifestations. Like if you have lung manifestations, then you have other symptoms than if you don't have lung manifestations. Of course, we have this muscle symptoms with weakness, commonly symmetrical distribution, sometimes accompanied by pain, but it's not dominant, and complaints of decreased functional capacity with difficulties getting up from a seated position, maybe climbing steps, raising arms or head. And sometimes, in addition to muscle problems, you will have symptoms from other organs like the skin with itching, rash, and maybe calcinosis, or mechanics hands, and that's skin changes on the outer side of the fingers. You could have lung symptoms with dry coughing, shortness of breath, heart symptoms with heart palpitations, chest pain, shortness of breath as well, just like when it's the lungs. Throat symptoms with swallowing problems. Sometimes this can be really, really severe and you can be unable to swallow. Joint problems with pain and swelling, sometimes stiffness. Symptoms from the vessels with Raynaud, and that's discoloring of the fingers and the toes. And finally, but not less important, general symptoms with fatigue and pain, sometimes causing severe handicap in daily living. And these symptoms are some of the most annoying symptoms if you ask patients. So how many and who are affected by the disease? You can have myositis from wherever you live. We don't know exactly how many have myositis, but the estimated, and that's estimated prevalence of myositis from 5 to 22 per 100,000 persons. So it's rare. We know that it's associated with female sex, and you can have myositis at all ages, including kids, but it's increasing with age. So how do we make the diagnosis? It's multidisciplinary, meaning that it's doctors from like dermatology, neurology, rheumatology, and I could go on. And it's also non-doctors, it's physiotherapists, and so on. The diagnosis of myositis, I have separated like to diagnose myositis and to diagnose other organ manifestations. The diagnosis of myositis will be based on a combination of symptoms and clinical signs, muscle biopsy, imaging like MRI, blood test, including measures of autoantibodies, meaning myositis-specific or myositis-associated autoantibodies, and measures of muscle enzyme levels, and that's illustrated below. This is an illustration of a muscle test, just a simple one for biceps. We have international validated and standardized muscle tests specifically for myositis patients. And blood samples, just mentioned. Muscle biopsy, it can be done in many different ways with a needle as well, depending on the site and the country. And this is an illustration of imaging. This is an MRI scan of the thigh. And these are only examples. So how do we diagnose the extramuscular involvement? And that include, of course, symptoms as well, just like before, in combination with biopsies that could be from lung, skin, imaging like X-ray of the esophagus and joints, CT scans, PET-CT, ultrasonography, lung function test, electrocardiography, and echocardiography. And this is an ultrasound of the heart, the function of the heart. And these, it's exemplified below, and it's only examples. This is an X-ray of a hand. This is a picture of electrocardiography, a CT scan on the chest, and you see the lungs and part of the heart as well. And this is the equipment for lung function test. It might look different in different countries. So how is the disease treated? It's again a combination of a multidisciplinary team. And I borrowed an image, a figure from this before mentioned review again. Thank you, Ingrid. And the treatment is based on medical treatment and non-medical treatment. The medical treatment will be immunosuppressive medication with glucocorticoids in the beginning, high dose, tapered, and hopefully to zero. And in combination with other immunosuppressive drugs, and in this figure you see the glucocorticoids and first-line drugs, methotrexate, for example, second line, third line, that could be rituximab, IVIG for all lines, and experimental therapy as well. What you choose depends on the symptoms, the signs, and the country too. Not every country has have access to everything. And then we have the non-medical treatment, which is really important, and that's physical exercise. And it's exemplified below, a combination of strength training and cardiovascular exercise. And that could be biking, like this image. It could be walking, running, swimming. And then finally, we have patient education, and that's actually what we're doing now. And then I will leave and give the floor to Olga and Silke with your testimonies, please.
I'm Olga. Yes, thank you very much for giving me floor. Silke and I are both ERN ReCONNET representatives. We are both chairs for patient organizations, and we are both patients with myositis. We will share with you our experience with a rare autoimmune disease, myositis. We will focus on prevalence in our countries, first symptoms, then we change the order, firstly diagnosis, then test, on treatment, patient organization, and World Myositis Day.
Thank you, Olga and Louise. The prevalence of myositis is depending on different causes. Louise had said that the prevalence of myositis is 5 to 22 in 100,000. Even this is different from country to country. Around 83 million people live in Germany, and around 10 million people live in the Czech Republic. These numbers would mean that around 2,000 people with myositis live in the Czech Republic. In Germany, there would be around 10,000 people with myositis. And Olga and I are one of them. And Louise, please, next slide.
Yeah.
Sorry.
First symptoms appear with the onset of the autumn weather in September 2013. It was painless muscle weakness, which caused limitation in my movement and great fatigue. I had problems getting out of the car. I got problems getting out of the bus, drying my hair, raising up my hands, and so on. I experienced pain in my knuckles of fingers. My fingers were swollen, and I had roughing and cracking skin on my sides of fingers. I consulted a general practitioner who, after a few days, referred to me a local rheumatologist who attributed my problems to my age, which was quite overwhelming for me. I underwent several examinations which didn't lead to a diagnosis and to a suitable treatment. Next slide, please.
Thank you. 1996, it started with pain in my hips and red spots in the face. A rheumatologist thought it was lupus. My family and I had to move several times, so that I had to visit different rheumatologists, and some of them thought it was lupus. Some of them said it's not lupus, but we do not know what it is. From 2006 to 2012, more symptoms occurred. This included muscle weakness, dysphagia, muscle pain, and double emergence. And as Olga explained, I couldn't walk stairs, I couldn't raise my arms, and I couldn't eat very well. And yeah, that was for a long, long time. Next slide, please.
Thanks to my friend, who is rheumatologist and lives and works in Germany, I was hospitalized in March 2014 in the Institute of Rheumatology in Prague. And after a few days, based on blood test and muscle biopsy, I received diagnosis of poliomyositis, interstitial lung disease, anti-synthesized syndrome with positivity antibodies JOY1. The diagnosis was rather surprising, but on the other hand, it was a relief that after almost 8 months, I received diagnosis. I believe that I reached the expert and I would be able to continue to function with certain limits. Waiting for diagnosis was the most complicated and most difficult period in my life. Next slide.
I was diagnosed with autoimmune hepatitis and autoimmune gastritis in 1990. Polymyositis was diagnosed in 2012. That was 16 years later after the first symptoms. In 2015, there was a suspicion of myasthenia gravis due to the AChR antibody and some other positive tests. A short time later, the Wo52 antibody was found to be positive. Overlap myositis was therefore more likely than polymyositis. Next slide, please. This suspicion was confirmed by these diagnoses such as Renault syndrome, polyneuropathy, autoimmune thyreopathy, mixed connective tissue disease, Sjögren syndrome, motility disorder of the esophagus, and myocarditis. For me, living with overlap myositis is like a roller coaster ride because the symptoms and the diseases don't occur every day and not with the same intensity. Next slide, please.
I visit my rheumatologist and pulmonologist regularly in 3 months intervals, and I undergo a lot of tests, blood test, antibodies, CK level, muscle biopsy exactly after the diagnosis, because it was a proof of this illness, muscle strength, lung functional test, imaging scans like X-ray and computed tomography of my lungs, bone mineral density test. For example, next month I have appointment with the expert for bone mineral density test. Next slide.
Thank you. Many tests have been carried out in the recent years, including blood tests, EMG, MRIs, muscle biopsy, PET-CT, X-rays, the Schirmer test, electrocardiogram, capillary microscopy, and much more. And I have more tests than I have listed here because the list is very long, and we want to show what it's necessary to diagnose a myositis. Next slide, please.
Because myositis is a heterogeneous illness and it has several root causes. A patient with myositis can be diagnosed by rheumatologists, neurologists, dermatologists, cardiologists, pulmonologists. Maybe Louise underlined these experts who can diagnose patient with myositis. Next slide. Louise said that there are different aspects to the treatment of myositis. Is true. This include medical therapy, physical therapy, speech therapy, logopedia, occupational therapy, and rehab. Next, please. Luckily, the treatment worked well, and I went back to my work. I was the inspector of the secondary cycle of the European school. I was responsible for European baccalaureate. I travel around the Europe because the European schools are located in several European countries, and I bravely fought with my myositis. Since 2013, I have been taking glucocorticosteroids, Medrol. After diagnosis, I took immunosuppressants, firstly methotrexate, and because I had progress in my lungs, my rheumatologist changed these immunosuppressants, and I took at the time equilmilon. And just now I took equal cyclosporinone, 50 milligrams in the morning and 50 milligrams in the evening. And Louise underlined non-medicated treatment is very important for patients with myositis. It's physical therapy. I exercise regularly. And if I miss one day, my body let me know right away. I prepare as a chair of the patient organization, I prepare booklet for patient we exercise with myositis. This year we prepare application for mobile phone with 12 training units for patient, and each year I organize rehabilitation workshop with physiotherapists and occupational therapists. And psychological counseling is very important too, because patients exactly after the diagnosis need psychological help. We as a patient organization offer 4 sessions with psychology free of charge. And rehabilitation, last month, I finished the 20th rehabilitation unit, which is free of charge in our country according to the law. And we can ask for staying in spa for 4 weeks and stay there for this rehabilitation. Next, please.
I have shown that my first autoimmune disease started in 1919, and so my medical therapy also started in 1990 with glucocorticosteroids. I get 19 years azathioprine. 5 years ago, I changed to mycophenolate mofetil, and since 2013, I get intravenous immunoglobulins every 4 weeks. My non-medical treatment includes physical therapy, speech therapy, and occupational therapy. Next slide, please. Just like the diagnosis, various specialist disciplines and experts are involved in the treatment of myositis. These may include rheumatologists, neurologists, dermatologists, cardiologists, pulmonologists, physical therapists, occupational therapists, and speech therapists. Next slide, please. It is not the most important thing whether a rheumatologist or a neurologist or others diagnose and treat myositis. The most important thing is that it is an expert in the field of myositis who is very familiar with the clinical picture. Next slide, please. In addition to the scientific expert, there is a network that offers additional support to patients with myositis, the patient organizations. Patient organizations provide patients with relevant information, education, and support to help them understand their disease, treatment options, and potential outcomes. They engage patients in targeted activities and support their mental well-being, which has a positive impact on the course of treatment in patients with myositis. Next slide, please.
On the occasion of World Myositis Day, this webinar is being broadcast. This rare disease was commemorated for the first time on September the 21st, the day when the World Myositis Day was established last year. This idea was initially expressed by Silke, and she was enjoyed by representatives of other myositis communities from the UK, Canada, the USA, the Netherlands, Sweden, the Czech Republic, and Australia. 2 weeks before September the 21st, we had an online meeting with representatives of myositis communities. We inform each other about activities which are prepared for this special day. And on September the 21st, we were in contact via WhatsApp and share experience from that day, share pictures, short films, and so on. It was really something extraordinary and amazing. Next slide, please. Living with myositis, there are some aspects which are very important for treatment and life of the patient with myositis. Early diagnosis is extremely important because changes in the human body during the course of illness are irreversible. Effective treatment and therapies are important too. Rich and balanced diet play extremely role for patients with myositis, and social relationships is families, support of families and friends is important too. And Silke spoke about patient organization. And the last shape is mental well-being of patient with myositis. All these aspects are interconnected, and it shows holistic approach to patients with myositis.
Yeah, and this is, if you want to know more about myositis, we have sort of linked or put in some links for ReCONNET for Armios organization, and that's where Silke, she will have a part in this organization. And finally, WHO, which is the World Health Organization, and I put that one in because they have recommendation for physical activity. And then finally, thank you. And now it's time for questions and answers. And we hope that you have some questions for us. Ingrid?
Thank you. Thank you so much, Louise, Silke, and Olga, and in particular to Olga and Silke for sharing your personal histories. And I think they are quite illustrative of the disease, of the heterogeneous disease, the need for multidisciplinary teams. So I think that's important to spread the information in general public, among medical students, to learn to think of this disease. And I would also say that I would also like to mention the Myositis Association, because that's the international patient support group. And I see Linda Corbett is in the chat, and of course very important in the Myositis Association, which also can give a lot of information on this disease.
And and thank you, Ingrid, for mentioning that. I'm so sorry, I forgot that one. That's a problem with mentioning something. Yeah. But in the Armios organization, you will find all the links to patient organizations. They have everything.
So we can take questions. I understand in the Q&A. There are no questions yet. We can also take questions in the chat. And we have Dr. Alain Mayer with us, who is co-chair of the ReCONNET Myositis Disease Group. And maybe we can invite Dr. Alain Mayer to maybe give a comment or ask a question.
Hello, thank you very much for this very insightful talk. Yes, I would have a question for Olga and Silke. And my question as a physician is on the patient point of view, what will be for you the greatest unmet need in myositis that we should address in the upcoming years? What is your perception of unmet needs as a patient?
I think it's early disease, an early diagnosis, because some patients are going from doctor to doctor about 20 years or longer, and they have no diagnosis, and they are suffering, and they don't get any medication treatment, and they are lost, and they are very, very helpless. And I think that would be the most important point.
And I would like to say that if for example, patients are diagnosed with myositis, early diagnosis is very important. I mentioned it during my speech, and maybe after diagnosis, it's necessary to be optimistic. And because I mentioned too that our muscles are ill, that's necessary to exercise regularly and to keep your body in good physical conditions.
Yeah, thank you both. And I agree, and that's something we need to work on together, how to disseminate information about this rare and complex disease on many levels. And I think ReCONNET is one platform to use. I see we have a question from Dr. Kutolo about sarcopenia, and also the importance of using calcium and vitamin D in addition to the immunosuppressive treatment. I don't know if Louise, if you want to say something about sarcopenia, because that's within your particular research field.
Yeah, thank you, Ingrid. Yes, I think it's really important. Sarcopenia, in more common terms, it's when you have loss of muscles, so you are sort of in need of more muscles. And I think that it's not. We haven't. It seems a bit crazy, but we haven't had that much focus on the diagnosed sarcopenia in myositis. But recently there have been some papers about sarcopenia. It's measured by DEXA scan. But we are sort of trying to do something about, we're treating sarcopenia with exercise and recommendations of exercise, and especially Associate Professor Helene Alexandersson from Stockholm in Sweden. She has done a tremendous work looking into exercise, effect of exercise in patients with myositis. So that will be the treatment for sarcopenia, but it's true we haven't looked that much into the diagnosed sarcopenia, which means loss of muscles.
Thank you. Yeah, please.
And so in this next question, replacement with the calcium and D vitamin, of course, that's necessary when you have prednisolone, and that will sometimes cause osteopenia, which is loss of bone. And that's why you have to have calcium and D vitamin if you are treated with prednisolone or glucocorticoids, and sometimes you'll have to continue even though you have stopped that treatment. Hopefully that was answer for the questions.
Thank you, Louise. We have another question we have in the chat. That's from Dr. Louise Pyndt in Belgium. He has a question concerning multidisciplinary workup consultations in relation to the healthcare structure. He explains that in Belgium, except for university hospitals, we are paid as physicians on a pay-for-prestation way. This means that for a multidisciplinary consultation, the patient has to be several times to each physician, or the different specialists are not paid, as is the case in actual multidisciplinary consultations. I would be interested to know if this is differently organized in different countries across Europe. And I don't know if Olga or Silke, do you have any information on this payment structure in your countries or in general in Europe?
Generally, my treatment is free of charge, but maybe I spoke about rehabilitation, and if I need more than 20 rehabilitation units, I pay myself this rehabilitation, but everything is free of charge for me.
Yeah, and in Germany, the health insurance takes the biggest part of the recipe of the doctor, and for physical therapist or occupational therapy or speech therapy, and the patient has to pay 10% of the recipe. Yeah.
But do you know anything about the payment or to the doctors from the healthcare system, if that is how that is distributed? I believe the systems vary a lot between countries. So I would you be interested to hear, Dr. Diederichsen, what you say? How is it in Denmark?
In Denmark, I think the system in Denmark and Sweden are quite alike. In Scandinavia, at least, it's sort of the same. If you think you have the diagnosed myositis, or a doctor think you might have myositis or rare disease, you will be seen in university hospital. You will be admitted to a university hospital, and in that university hospital, you might be seen by different specialties like dermatologist, what you need, pulmonologist, whatever, but it would be within a university hospital.
Yeah, I think that's the same with us. But if we then even in the university hospital, if I see the patient one time, they go to a lung doctor, or we need to have this, we have this collaboration. But if the patient is coming to the clinic, we have to have different appointments. So that's, I guess, the same. Even
It's the same.
The university hospital.
Yeah.
We try to combine them on the same day, and then we have a discussion, but we have to make 2 different appointments, just as Dr. Pyndt says.
Yeah, it's the same in Denmark. We are trying to do like you do, Ingrid. When the patient has to travel to the hospital, we try to put all the appointments in with the different departments, but it's really complicated due to sometimes many different departments are involved, and it might be, it's really difficult.
I see a comment from Dr. Alain Mayer that in France, the doctors have a salary that's not directly indexed on the number of prestations, so we do not face this barrier for multidisciplinary consultations. So that's, it's different. We are not individually paid, but our hospital and our clinic is paid based on the number of visits. So it's on another level. We have one question here in the Q&A. That was the question. Then we have another question from Dr. Kotolo. Which is the best sport you should suggest to help the muscle activity in patients with myositis when possible?
Yes, thank you very much for this question, because I was an active person during our life, and I skied, I ride the bike, and I travel, and I like or loved to a tourist. Yeah, but just now I have to lower my speed life, and I like aerobic. I like exercise. I still ski, but only because I listen my body signals. I ski only one day, and then one day I would break, and maybe for 3 hours. It's consultation with my rheumatologist, and maybe walking. Walking is for me very important. Daily I walk maybe 10,000 space, for each day, and it's important to exercise each day, to walk, maybe to go for a walk in the afternoon, in the evening. It depends on time, on the weather.
Thank you, very wise. Any comment from Silke?
Yeah, I think walking and swimming is very good, and go riding a bike. But I think also that every sport is good. Do nothing is not good, but do anything, do something is very good. And if you have the power to do some sports, do it. Do it, do it, do it. I'm going to the gym. I'm not going skiing or hiking or swimming, but I'm going for a walk and I'm going to the gym. And I think if your body is able to do that, you should do that. And you have to listen to your body. Is it okay or is it not okay? And then you can change the strength, the power, the limit, and yeah.
Thank you. Louise, do you want to comment also on the different types of sports or exercise?
Just like I really agree, Silke. It's better to do something than nothing. Yeah. So and sometimes if you don't like to do it, I think in the beginning, it's not, if you're not used to doing sport, I think it's really important to say to patients that's my advice to patients. Sometimes it's wonderful if you enjoy it, but it's just like a pill.
Yeah.
Yeah. And you don't ask yourself if you like your pill, the taste of the pill, the color of the pill. You eat the pill because it's healthy for you and it's a way to get more healthy again. So sometimes if you don't like doing sport, and many people have never done sport before, and then I say when they are at their lowest physical level, I ask them to do sport and exercise. But it had helped some patients that I said to them, it's okay if it's wonderful if you like it, but especially in the beginning, it's just a pill.
Thank you. We will have another webinar on exercise in the spring, I think. So then we can discuss this more. But what I learned from our physical therapy is that any type of exercise is beneficial. And as you say, not doing anything is bad. But you should do what you think is fun. So it's something that you keep on. So persistence and sort of to raise the threshold of resistance is important. And we are currently analyzing a study where we used high intensive interval training. It's also working very well for patients with myositis. So it's more what you like and what you think is fun to motivate you to continue. I don't see any more questions. And we are almost reaching the end of the 45 minutes. Is there something from our panel, Silke, Olga, that you would like to add here?
No.
Thank you very much.
Thank you.
This will be then recorded, or it is recorded and will be reached through the ReCONNET website. And we have had already some webinars on myositis, and we will also produce new webinars during the coming year. So keep posted and go into the ReCONNET website and look for information. And future research. Oh, here is another question just before we leave. As physicians, we frequently face the question of nutrition. And of course, this has been poorly addressed. And there is a question, if in your journey, have you found some response or some the nutrition, food, and something you would like to comment on? And maybe this is something for future research. Have you come across something with concerning nutrition and food, Olga and Silke, that you?
I tried to avoid sugar and white meat flour and so on. And I tried for 3 months to eat very healthy, and it doesn't work for me because I was very weak. I was not in a good condition, and I said I missed something, and I don't know what was going wrong, but it was not a good way for me.
I think if you want to change your diet, and particularly in the beginning of the disease, when you may have lost a lot of muscle, it's very important to have consultation with an expert in diet.
Yeah, I had, but and we do a nutrition plan and exercise plan that doesn't work together. We're really good. No, it's not for me.
Yes, and sometimes it's very important to have meeting with nutrition. It's very good for patients with myositis, because it's necessary, as Silke said, eat healthy food. And maybe I would recommend this, because I watched this webinar about nutrition. It was focused on Mediterranean diet, but I think that it's example of good diet for patients with myositis.
For all people with inflammation.
Yeah.
Thank you so much. And as I don't think we have any more questions, I would like to thank you all, Louise Diederichsen, Silke Schlüter, and Olga Drapalova for this very, I think, valuable and interesting webinar, and it's worthwhile coming back to and to recommend to your patients to go and listen to. So thank you so much for today, and I guess we will be back later in this year or next year with a new webinar. Thank you so much.
Thank
Have a
you.
nice
Thank you.
day.
Thank you.
You too.